Hello everyone and welcome again. So continuing our discussion about the clinical pharmacology basic principles class. Now we are going to talk about the drug elimination. Now drug elimination is the final process of the drug cycle. We talked about how the drug is first absorbed into the plasma and then it gets distributed into different body compartments where it would have its effect, and then it would get metabolized into more polar molecules to be finally eliminated from the body by the process of elimination. So the process of elimination is dealing with the removal of a drug from the body. So removal of a drug. And here we will talk about some elimination concepts, starting with the elimination half-life. Then we will talk about the kinetics of a drug elimination, the steady state plasma concentration, also known as the CSS, and the clinical significance of the zero-order elimination, and clearance, and finally we will talk about the drug monitoring. So let's start. So let's start by talking about the elimination half-life, which is also known as the time half. So the elimination half-life is the length of time required for the concentration of the drug to decrease to a half from its starting concentration in the body. So the elimination half-life is the time needed for the drug to decrease from full concentration into a half concentration. And whatever that time, this is what we call the half-life. So let's make a graph between the concentration and time to make this more clear to you. Let's say we have the time on the horizontal axis here, and we have the concentration of the drug on the y-axis or on the vertical axis. And let's say we gave a person 10 milligrams of a drug intravenously, meaning all of the 10 milligrams are in the circulation of that person. And what we notice is that the drug concentration would be decreasing with time because of the process of the metabolism and excretion of that drug. So when the drug reached its half, meaning the 10 milligrams would be 5 milligrams here, the time needed to achieve that here, if we plot it here, it would be right here, and that's what we call the T half. So here we have more facts about the half-life. So first of all, when we say plasma half-life, it is more precise than just saying the half-life. It's the same expression, but the plasma half-life is more precise. Because we have another type of half-life, which is the biological half-life, and it is the time needed to eliminate 50% of the drug from the tissues, in comparison with the plasma half-life, which is the time needed to eliminate 50% of the drug from the plasma. So plasma from the plasma, biological from the tissues. Another fact is that the half-life is calculated by two methods. The first one is by giving the drug to the patient and then calculating the plasma concentration of the drug and plotting it into the concentration time curve and finding the half-life. And the other method is by the equation, which is clearance equals 0.7 multiplied by the volume of distribution divided by the T half. And we can find the T half because the clearance of the drug is available in resources and the volume of distribution is also available in resources. So it would be easier to find the half-life of any drug we want to the half-life of. The half-life is the same is the time when the drug is taken again. Like amoxicillin Q12H, which means the amoxicillin is taken every 12 hours, meaning the half-life is the interdosage time. Interdosage meaning it is the time between the doses of the drug. So in this example, the amoxicillin is taking, if I take the amoxicillin right now, I want to take another dose after 12 hours. Now let's talk about the clinical significance of the half-life. First of all, the half-life is useful in determination of the dosing frequency of a drug. Meaning, if the half-life of a drug, let's say, is 12 hours, this drug is taken every 12 hours. If the half-life of another drug is 6 hours, so this drug is taken every 6 hours. So it's helpful in determination of interdosage time. It's also useful in determination of a drug dose taken by a patient who is unconscious. And that's if the timing when the dose was taken is known. And that's by identifying the plasma concentration of that drug in the unconscious patient and then plotting it on the time concentration graph. And we can find the half-life from that, or we can find the drug dose from that. And there is another way to identify it, and that's from the volume of distribution, which we talked about in the drug distribution video before. Now let's talk about the kinetics of drug elimination. So the kinetics of drug elimination refers to the study of the rate at which the drug is eliminated from the body. So kinetics is related to the rate at which the drug is eliminated from the body. And we have two orders of a drug elimination kinetics. We have the first order and we have the zero order. The main factors affecting the kinetics by which the drug is eliminated is the chemical properties of the drug itself. So different drugs would have different kinetics of elimination, and also the dose of the drug is given, which is the second factor here. Understanding the kinetics of drug elimination is important to first predict the duration of action of the drug, and it can also help to determine the appropriate dosing regimens for the different patient populations. And the most important one is to predict the likelihood of the side effects associated with a particular drug. So let's make a comparison between the first order kinetics and the zero order kinetics. And to make it easy, we will make a graphs between time and concentration for each one of these, so it would be easier to understand. And let's start with the first order. Let's make a graph between the time and the concentration. So time would be on the horizontal axis and the concentration would be on the vertical axis. And let's say we gave 100 milligrams of a drug that has first order kinetics properties to it. And what we notice is that the drug concentration would decrease with time and until it reaches 0. And what we notice is that when it reaches its half, which is 50, that would be by, let's say, a certain amount of time. It would be about, let's say, 6 hours. And then it also gets halved again by the same amount of time, by the same half time here. So it would be halved by 12 hours, and it would be also halved again, that's by 18 hours, and that's into 12, and then into 6, that's by 24, and finally into 3, and that's by 30 hours. It will be 3, and that's when it gets eliminated fully from the body. Hypothetically, it will get fully eliminated from the body. So if we count those, we would have 1, 2, 3, 4, 5. It would be by 5 half-lives, it would be almost fully eliminated from the body. And that applies to all the first order drugs. It would be fully eliminated by 5 half-lives. The same would happen if we bring the same drug, but this time we give 1000 milligrams of the same drug. It would also get to 500, and that's by 6 hours. And it would get to 250, and that's by 12, and so on. It will get to 125 by 18, and so on. And what we notice here in the first order is that a fixed ratio of the drug is getting eliminated per unit time. So a fixed ratio, which is 50% of the drug, is getting eliminated per unit time. And that's what differentiates it from the zero order. Let's make also a time concentration graph here for the zero order. So here we have the concentration on the vertical, and we have the time on the horizontal. And let's give the patient also 100 milligrams, but this time we gave them a drug that is zero order, that is eliminated by zero order kinetics. And the drug, the elimination of this drug would be 10 milligrams every hour. So let's make those. So 100, 90, 80, 70, and so on until 0. And we have the time here. We have 1 hour, 2 hours, 3, and 4, and 5, and so on. What we notice that with time is that the drug would be decreased by 10 milligrams every hour. So it would be 90 by 1 hour, and it would be 80 by 2 hours, and 70 by 3 hours, and so on. And what we notice here is that so let's say we give this patient 1000 milligrams of the same drug that is eliminated by zero order concentration. What we notice here is that the drug is still eliminated by 10 milligrams every hour. So it would be 990 after 1 hour. It would be then 980 by 2 hours, and so on. And what we notice here is that fixed amount of the drug is getting eliminated. Fixed amount of the drug is getting eliminated, and the amount is different for every drug. Like, let's say this drug would have 10 milligrams every hour, another drug would have 20 milligrams every hour. And it is different depending on the type of the drug or the chemical properties of the drug itself. And that's the main difference, is that in the first order, there is fixed ratio. 50% of the drug is getting eliminated every unit time. While here we have fixed amount, 10 milligrams every hour, or a different number every hour depending on the type of drug. Here we have more comparison points between the first order and the zero order. So again, in first order there is constant ratio of the drug is eliminated per unit time, and the ratio is 50%. So the drug is eliminated to a half every unit time. And this also means that the rate of elimination is proportional to the plasma concentration of the drug. The higher the concentration, the greater the rate of elimination. As we saw in the example, the drug level was 100 and it would reduce to 50. Even if it's 1000, it would reduce to 500, and that's in the same unit time. While in the zero order, there's constant amount like 10 milligrams every hour of drug is eliminated per unit time, and it does not proportional to plasma concentration. It will still 10 milligrams in any concentration. And the first order kinetics occurs to most drugs like phenobarbital, while the zero order would occur to a limited number of drugs like alcohol. Elimination in the first order doesn't depend on saturable enzyme system. The enzyme system in the elimination of the first order kinetics would able to handle any amount of drug, while here in the zero order it depends on saturable enzymes. So once the enzymes get saturated, the drug would stop, the elimination process would be stopped. That's why there's constant amount of the drug is eliminated per unit time, because once the enzymes are saturated, the rest of the drug would stay in the circulation and can't be eliminated until the enzymes would be free again, and they would take another amount of drug and try to eliminate it too. In the first order, you can expect the plasma concentration at any time, and the drug is eliminated after the 5th half-life. As we mentioned in the example, the drug would be after 5 half-lives, it would be almost gone from the body. While here in the zero order, you can't expect the plasma concentration well, because there's a lot of factors affecting it. In the first order, the drug accumulation is not common because there is fixed ratio of the drug is eliminated, and we always can expect the plasma concentration, so the drug accumulation would not be common. While in the zero order, the drug accumulation and toxicity is common because there is a lot of factors affecting this, including the concentration of drug. If it is high, this would be toxic to the patient because it would take a long time for the drug to get eliminated from the body. Like for example, if the patient took the wrong dose, it would be very toxic to them because the body would not metabolize the drug or eliminate the drug very quickly. The same with the first order. And also the other factor is that there is competition on the same eliminating enzyme will lead to the same problem. Meaning if the patient is taking another drug that is also eliminated by the same enzyme that is eliminating this drug, this would lead to toxicity because one of those drugs would not be eliminated and it would accumulate in the circulation. Another point is that the half-life is a constant number in the first order kinetics, while the half-life is changing here on the zero order depending on the concentration of the drug is available. If there is competition on the same eliminating enzyme or not, and other factors. So the half-life would depend on the concentration of the drug, if there is competition on the eliminating enzyme, and other factors that affect the half-life. Now let's talk about the steady state plasma concentration, which is abbreviated as concentration steady state, the CSS. And the steady state plasma concentration means the steady drug level in the circulation, and that's achieved when the rate of administration equals the rate of elimination. And we reach the steady state plasma concentration by supplying the eliminated part of the drug. And we try to reach the steady state plasma concentration because the drug would be effective all the time during the CSS. During the steady drug level, it would be effective all the time and would give us the effect we want. So let's take example for the steady state plasma concentration. And let's say we gave a person a drug dose of 100 milligrams of a drug that is eliminated by first order elimination, and the half-life of that drug would be about 6 hours. And let's draw a graph between the concentration and the time. So we have the time here. Here we have the concentration of the drug, and we start with 100 as we mentioned, and let's say this is the 100 here. So 100 milligrams, we give this person 100 milligrams of first order elimination drug. It will decrease into 50 in about 6 hours, which is the first half-life. And we also mentioned that the half-life is the same as the interdosage interval, meaning we will give this person another dose at the same half-life. So at 6 hours we give them another dose, and it would be 150. So it would here decrease to 50, and we give them 100, it would be 150, and it would decrease into 75, because half the 150 is 75, and that's by another half-life, which is now 12 hours, and we would give another dose. It would be 175, and by another half-life it would be 87, which is here, and that's by 18, and we would give another dose. It would be 187, and it would also decrease this time into 90, and we also give another dose. It would be 190, and we decrease into 95, and this time it would be about 200, and when it reaches half-life it would be 100, and that's so we give here one half-life, the second half-life third, the fourth half-life, which is 24, and then the fifth half-life here, which is 30. And then at the 100 mark, when we give a dose, it would reach 200, and it would go down to 100, and it would reach 200, and it would go down to 100, and so on. And that's when we reach the steady state at this point. So at this point, this what we call the steady state plasma concentration, meaning the concentration of the drug would be steady between 100 and 200. And that we reached here after the first, the second, the third, the fourth, the fifth half-life, which is, so we reach the CSS after 5 half-lives. And that's after 5 doses of the drug, we reach the steady state plasma concentration, and the peak level of the steady state plasma concentration, which is here 200, we would call it the peak, which is the highest concentration, and the lowest concentration, which is 100, we call it the trough level. And the range between the peak and the trough would be called the therapeutic range. Now here we have some general facts about the steady state plasma concentration. So again, we reach the steady state plasma concentration after 5 half-lives, as we saw in the example. And if we change the dose, the new steady state reached after 5 half-lives too. So it would also take 5 half-lives if we change the dose. If dosing stops, the complete elimination of the drug from the plasma occurs after 5 half-lives too. So meaning we reach CSS after 5 half-lives. If we change the dose, we also reach it after 5 half-lives, and the drug is fully eliminated after 5 half-lives. And the steady state plasma concentration is 1.5 of the dose. In the previous example, it was 100, the dose we give, and if the steady state would be 1.5, so it would be about 150. So the steady state would be 150 here. And you can reach the steady state plasma concentration with 1 half-life, and that's by using the loading dose. And this, the loading dose would be explained in the next slide. But all of this explanation is for the first order elimination. Let's explain the steady state plasma concentration in the zero order elimination. So let's make a graph between time and concentration. So here we have the time on the horizontal axis, and here we have the concentration. And let's say we gave 100 milligrams of a certain drug that is eliminated by 10 milligrams per hour to the patient. And after 1 hour, we notice that the drug level would be at 90 here, so 90, 80, 70. So it would be 90 after 1 hour. And to reach the steady state plasma concentration, we must supply 10 milligrams every hour. So we would give 10 milligrams every hour, and it would reach 100, and it would be like that. And that's hard because we can't give the patient the drug every hour. It would be not suitable. Also, let's say if we waited 2 hours or 3 hours here, and we give, let's say, 30 milligrams of the drug, and it would be like that. It would be also here we might, if we reach 70, this might be not the therapeutic level we want. So it would be also a little harder for us to reach the steady state plasma concentration, even if we wait, because the trough level might be not therapeutic for the patient. And also 3 hours would not be that great, because it's hard to take the drug every 3 hours for the patient. Yeah, and also if the saturable enzyme that the drug was is occupied by another drug, this would make it even harder for us to reach the steady state plasma concentration. So there's a lot of factors affecting the zero order, and it is a little bit harder for us to reach the steady state plasma concentration with the zero order elimination. But we need to monitor the drug more during the zero order more than the first order, because if let's say the patient took the wrong dose, or if the patient is taking another drug that is also metabolized by the same enzyme, this would lead to toxicity to the patient, and we don't want that to happen. So the zero order elimination steady state plasma concentration is a little bit harder than the first order. Now let's talk about the loading dose. We mentioned that we can reach the steady state plasma concentration with 1 half-life instead of 5, and that's by using the loading dose. So this would be a faster way to reach the steady state plasma concentration, and that's very helpful in serious infections and arrhythmias, emergency conditions, because we need to reach the CSS very quickly, so the patient would have the good therapeutic effect happening to them very quickly. But there is risks or disadvantages to the loading dose, is that there is an increased risk of drug toxicity and accumulation, and there is a longer time for the plasma concentration to fall if the drug is accumulation occur. So let's explain the loading dose now on the time concentration curve, and let's take the same first order example, is that we give the patient 100 milligrams of a certain drug, but this time instead of 100 we give the patient two doses, which is 200 as the first dose. What we notice here is that the drug would be eliminated in 200, and then at the 6-hour mark we would give them another dose to make it 200 again, and it would be 100 by the 12 hours, and like that. So as we notice here is that we reached the steady state plasma concentration with 1 half-life instead of 5 in this example here. So it would be very convenient for emergency conditions, because we would reach this steady state very quickly. Now let's talk more about the zero order elimination, and that's about the clinical significance of the zero order elimination. So important point to look for in the zero order elimination is that modest change in drug dose may produce unexpected toxicity. So we need to be very cautious with the zero order elimination drugs while changing the dose. Elimination of drugs or attainment of the steady state plasma concentration takes long time, as we mentioned before. Also, if the patient change formulations by buying another type of the drug, this might lead to toxicity too, because other formulations might have additives or have another drug combined with, or it would have higher dose, and the patient is not attentive to that. And we mentioned that the drug accumulation and drug-to-drug interactions are common in the zero-order elimination. Now let's talk about clearance. So clearance is the volume of plasma become cleared from some substance per unit time. For example, drug clearance is 100 milliliter per minute, meaning that 100 milliliter of plasma cleared from that drug in 1 minute. So it is volume of plasma become cleared from some substance per unit time. So we have multiple routes of elimination, like the kidney, which is the most common one. The liver is the second most common, or most drugs are eliminated by them. And then we have the sweat, tears, breast milk, and lungs. Kidney is the primary organ of drug elimination, and the liver comes next, and then we have the other routes. So here we have the kidney nephron, and we will explain the clearance on it. We all know from physiology is that the blood will come from here through the afferent arteriole, and it would go into the glomerulus and out through the efferent arteriole. And the blood, when it comes to the glomerulus, it would be filtrated into the Bowman capsule here and into the proximal convoluted tubule. So the drugs are filtrated into the Bowman capsule by the filtration process, and some drugs would be secreted here by active tubular secretion. So active tubular secretion would secrete some drugs into the filtrate of the kidney, and most of them would be filtrated into through the filtration process. And we all know that the glomerular filtration rate of the glomerulus would be about 100, of the kidney would be 125 milliliter per minute. And if the drug would have a clearance more than 125, we would assume that the drug is also would be secreted by the active tubular secretion, because the GFR is 125, and if the drug is higher than the 125, it means that it not only gets filtrated, it's also actively secreted into the proximal convoluted tubule, and it would be excreted by that method too. Now, the lungs primarily involved in elimination of anesthetic gases like isoflurane, because they would be in gas form and they would go out through the air. So it would be the lungs would be primarily involved in their excretion. The drug elimination through breast milk might expose the infant to medications and metabolites taken by the mother and lead to side effects in infants. So we need to take into consideration, if we give a drug to a lactating woman, we want to make sure that the drug is safe for her and the baby. And the drugs that conjugated in the liver are excreted through the bile and into the feces. So clinical significance of clearance. First of all, avoiding injury of diseased organs by avoiding drugs that are cleared by that organ. So if the patient has renal impairment or liver impairment, so if they have renal impairment, for example, we try to give them drugs that are eliminated by the liver. So it would be so we would not expose the kidney into more toxicity. And if the opposite, like if the liver is impaired, we try to give them a drugs that is cleared by the kidney. So solved by giving drugs that are cleared by another organ. If there is no alternatives, then we try to dose adjustment. We try to decrease the dose of the drug. Also, in the clinical significance of the clearance, we have this formula. It's a famous formula. So clearance would be equal to 0.7 multiplied by the volume of distribution divided by the T half. So through this formula, you can identify the half-life and subsequently the dose of the drug that you should give if you know clearance of that drug, thus avoiding accumulation. So it has many uses. This formula is important to remember. Also, in the clinical significance of clearance, if the drug is cleared by certain organ, we can make it a targeted therapy for that organ. Like in the urinary tract infections, we use antibiotics that are cleared by the kidney, like the nitrofurantoin. So it would be cleared by the kidney and it would work on the urinary tract infections in the kidney because it would be targeted through to the kidney. And also, in the clinical significance of the clearance is the ion trapping. That's when we manipulate the urine pH to trap drugs that are accumulated in the body. We would try to trap them in the urine and excrete them. For example, weak acids can be eliminated by alkalinization of urine. That's using effervescents. Those are drugs that would alkalinize or acidify the urine. That's depending if we have weak acid drug that has toxicity, we make the urine alkalinization, and if it's weak bases, we try acidify the urine. We talked more about the ion trapping on the drug absorption video if you want to check it out. Finally, let's talk about the drug monitoring. So drug monitoring is monitoring of drug levels in the plasma to optimize therapy and avoid toxicity. And not all drugs are monitored. mostly when we monitor the zero-order drugs, so drug monitoring is calculated by either calculating the drug level itself in the blood or calculating the effect of the drug, like in warfarin, the anticoagulant. We calculate the international normalized ratio of the blood, which is an effect of the warfarin. If we give warfarin, the INR would go up. So we try to monitor the warfarin by the INR, and it is level of coagulation of the blood. The usual number is 1.2, and when giving warfarin, it increases. So clinical significance of the drug monitoring: when we monitor the drug, we try to avoid toxicity while using the drug with narrow therapeutic index, meaning the dose gap between therapy and toxicity is small. So drugs with narrow therapeutic index would require monitoring, like the digoxin, the warfarin, and the lithium, and also avoid toxicity in patients who have renal impairment or liver impairment by monitoring the level of the drug and adjusting it. And we also, as we mentioned before, that we monitor the drugs with the zero-order elimination. So we monitor and avoid toxicity in narrow therapeutic index drugs, and in patients who have renal impairment and liver impairment, and also in zero-order drugs, and differentiation between drug resistance and patient non-compliance. We try to identify the drug level in the plasma, and if it is low, means the patient is non-compliant to the medication, and if it is normal, this means there is resistance to the drug, like in the antibiotics. If the drug is normal levels in the plasma and there is no effect, this means the antibiotic is not working. So with that, we reach the end of this video. Thank you guys for watching. Please make sure to like and subscribe, and if you want to support more, you can by subscribing to the Patreon, link provided in the description of this video. Thank you for watching, and see you soon. Peace.